Hey, Erik.
Hey, Bill, how are you?
Very, very well. Are you still at the clinic?
No, I'm on vacation this week.
Oh my goodness.
Thank you for
go
being
see-
with us on your vacation.
Sure.
We appreciate it.
It's dedicated.
Yes, very
Getting a
dedicated.
little,
I hope
getting a
that.
little fuzzy there, Erik.
Yeah, I had to cut it back. I had the full lumberjack, and my wife vetoed that. So
I would probably have one if I could, but I got a little gap right in here, and it makes me look like some kind of not good. But so, what are you doing on your vacation? Are you hanging out in Jacksonville at the TPC?
no, today I spent it reviewing our 70 epilepsy scans.
Awesome.
So
Awesome.
yeah.
So making good use of rest and relaxation. I see. That's good. That's very good.
Yeah, I'm gonna spend a little time with the family. I'm going to Portugal for a week, starting next week for a
wonderful
workshop that I was asked to present at. So I'll be away for a little while.
Okay, so kind of one of those work play sort of trips.
Yeah, the International Society of Magnetic Resonance and Medicine is like the kings of all MR technology and everything around the world, and they're holding a workshop on 7T in Lisbon.
Yeah,
and so they asked me to present there. So it's good.
Nice.
They usually don't include us lowly clinical people in the stratosphere of these big minds, but so we're making progress.
Great, good. I'm glad to see that's one for the clinicians.
Yeah. Yeah, I think there's like about 50 presenters and 5 MDs that I saw in the program.
Really? Oh my goodness. You're going to be surrounded. You're going to have to try to gravitate towards the doctors.
Yeah.
I don't know whether Sanjeet was operating today or not, but I'm hoping we can start on time and answer some questions. Maybe talking to Rachel, we can do a little bit of presentations, can show some slides. You can show some slides. Sanjeet can show some slides. We got about 15, 20 minutes, and then we turn it over to Q&A. Hey, Chris.
Hi, thank you. Sorry, I was just hoping someone get on the line.
Hi, welcome. That's okay. We haven't started yet. You're a few minutes early still.
Rachel.
Hi.
Hi, Rachel. We haven't met. I'm Mark Swanovic.
Hey, Mark. Nice to meet you. Thank you so much for joining us tonight.
Yeah, thanks for, nice to meet you virtually as well. And thanks for the invite, and looking forward to the program tonight.
Absolutely. Me too. We will get started shortly.
Awesome.
I just saw Sanjeet pop on. Hey, Sanjeet.
Hey, Bill, how are you?
Very good.
All
So you
right.
made it home. I was worried that you were in the OR still.
Oh, you know me. Never know where I'm going to be.
Looking, yep.
So thank you everyone for joining us. We'll get started in just a moment or two. I'm just waiting for a few more people to log on with us.
Hi, Rachel. Thanks for everything.
Hey, Misty, you're welcome. It's nice to put a face to the name. You are very welcome. We're excited for the sponsorship and partnership. So we're looking forward to some great information. All right, guys, we're going to go ahead and get started. I just got a message that Dr. Katani may be running a couple minutes late. I'm sure she'll have some words that she would like to share with everyone when she joins us, but I want to make good use of the hour that we have together. So let's go ahead and get started. My name is Rachel Stevens. I'll be your host for this evening. I'm so excited to be with you all again. If you're joining us for the first time, welcome. I hope you attend our future tea time sessions. And if you are joining us again, welcome back. I would like to remind everyone that tonight's session is being recorded and will be reposted on our social media platforms. Just a quick reminder as well, when we get to the end of the presentation, and it's time for the Q&A session, use the raise your hand feature. I will see that you clicked on that and I'll be able to call on you to ask your question. If you can't find it, you can also submit your question in the chat box and we'll be monitoring that as well with my co-host Jesse, who's also on the call tonight. And lastly, we want to give a huge thank you to our sponsor, Medtronic. We are very grateful for the sponsorship and to be working together tonight. And I would like to introduce you all to the district manager, Mark Swanovic.
Well, thank you, Rachel. Yeah, we're very excited today to bring you guys a really interesting and hopefully really valuable presentation. So on behalf of Medtronic, we'd like to introduce and thank our clinicians and thanks to the Epilepsy Florida group to really putting this together. It's a great opportunity to do some learning here today. We are really excited to bring you guys Dr. Sanjeet Greywall. He is in the Department of Neurosurgery. He is a senior associate consultant at the Mayo Clinic in Jacksonville, Florida, and has been a member of the American Epilepsy Society since 2016, and is very passionate around DBS surgery for epilepsy. We'll also be bringing you Dr. Erik Middlebrooks from the Department of Radiology and the professor. He is also a professor at the Mayo Clinic and College of Medicine, and is the program director for neuroradiology. And then finally, we're bringing you Dr. William Tatum from the Department of Neurology and is a professor at the Mayo Clinic and College of Medicine as well. He is a senior consultant and the chair of the Division of Epilepsy in the Department of Neurology at the Mayo Clinic. And today they're going to be speaking to you on behalf of DBS, Deep Brain Stimulation for epilepsy. These clinicians bring a ton of experience in the area, not just in Florida, but in the country. They're one of the best known for bringing this technique and surgery in for epilepsy. And this is a therapy that's offered all around the world. So without further ado, I'd like to thank the folks from, again, Epilepsy Florida and the Mayo group for being available today to present to you guys. And so I'll kick it off and give it to you guys and look forward to the presentation tonight. Thank you.
Well, thanks very much, Mark, and many thanks to Medtronic for supporting the evening, and also to Rachel from Epilepsy Florida for putting together this tea time. It's really a pleasure to be with everybody here tonight, and we look forward to a very interactive type of program where we can talk freely and you can ask questions and we can share a little bit with you about what we're doing at the Mayo Clinic. So I'd like to share some slides with you very quick. And if I can find them. Yeah, so we know, go back. Epilepsy is a very common problem. There's about 3.4 million people in the United States, 65 million people throughout the globe. That means there's at least 3 million people in the US and about 500,000 kids that have this condition. But what you may understand is that 1 in about 26 people having epilepsy. What I'm showing you in this slide is actually an artist with epilepsy who tried to depict what she felt before a seizure. You can see pre to the left, and what she felt after the seizure. And you can imagine the scrambled type of thinking that somebody has immediately after the seizure in the postictal state compared to that which is interictal. It's a slow sort of rebooting of the primary computer that we call the brain. And it's not to forget or overshadow what we see as a physical difficulty. Somebody that bites their tongue is one thing, but what many don't understand is that epilepsy can result in sudden unexpected death. And while it's rare, and while it's treatable if we can control the seizures, a lot of what happens in the day-to-day action of a clinic that dedicates everything that they have to epilepsy is seeing people that hurt themselves, and not just a bitten tongue, burns, broken bones, or even worse, car accidents from not realizing someone's had seizures. So what we normally do is approach people with a diagnosis. You can't treat before you diagnose. And it starts off initially talking in the clinic with MRI that Dr. Middlebrooks is going to show you, with different forms of EEG that we perform that either show an abnormality or not. But epilepsy remains a clinical diagnosis. And here we have a patient that otherwise is in our epilepsy monitoring unit to find out exactly what's wrong with her. Does she have epilepsy or not? If she has epilepsy and medicine hasn't controlled her, is she a candidate for other forms of either neuromodulation with neurostimulators or perhaps epilepsy surgery? And Dr. Greywall is going to share some thoughts with you about that. But behind the scenes, up there in the insert to the left, what you'll see is you'll see a series of lower monitors that contain the EEGs, and we couple that with the behavior of looking at videos on the top to identify that electroclinical type of spectrum that provides a 100% diagnosis. So we can confirm the diagnosis as opposed to suspecting the diagnosis in the clinic. EEG is a supportive tool, but it's only confirmatory when we're able to identify the pattern on the EEG up here in the left upper hand corner by showing us the same type of pattern that we see in patients with epilepsy. The brain is a delicate place, and I remember a former epileptology mentor used to say, the brain is where we live, and the brain is broken down into different eloquent areas that are important for language, for motor function and strength, for sensation, for language, for vision. These are all very delicate areas where if there's injury to these areas, such as in a stroke, that's where you may see patients that have problems with their neurological system as a result. So in those that have uncontrolled seizures, perhaps 1/3 of patients with focal onset seizures, where the network involved is in one part of the brain, we attempt to identify areas that are safe and accessible to situations that can lead to a surgical cure or reduction in the seizures. I'm showing you here this little green spot in the middle, which may be where we record the seizure onset. However, the area creating epilepsy in pink immediately surrounding that may be somewhat larger, may be somewhat smaller, may be more remote from where we see the abnormality on the EEG. But yet, what the surgeon looks at is the functional deficit zone, the area where, if it's sacrificed, it may result in types of symptoms that look like a stroke. So we've developed specialty types of EEGs at the Mayo Clinic where we use high density EEG in the form of 256 channels being placed on the head for certain individuals where we're able to refine and identify precisely where the electrophysiologic abnormality or the electrical activity occurs. Sometimes this is very useful and we can find it on the surface of the scalp, but other times we can't. And we do our best to work with our neuroradiology colleagues like Dr. Middlebrooks and our surgical colleagues like Dr. Greywall in an effort to provide every benefit to our patients that involve both surgery as well as neuromodulation. Now, these are some of the sophisticated types of maps that we can develop just simply by looking at the signals on the scalp. We can see exactly where these little waveforms here called spikes may be maximal. We can look at the topography of the brain, and we can even down here in the lower red and green type of depiction, co-registered on an MRI, look for source localization. And we can try to find exactly where the abnormalities on the surface of the scalp are derived. Sometimes it's helpful. In a smaller percentage of people, it's not. And we end up using intracranial EEG where we put electrodes in and around the brain to help define exactly where the seizure onset is, as well as trying to define exactly the safe areas that may or may not be able to be removed. If we can't find those areas, then we usually consider other forms of electrical stimulation. And you've probably heard of the vagus nerve stimulator, the deep brain stimulator into the thalamus and its nuclear complexes or different compartments, and the responsive neurostimulator. And we'll probably talk a little bit about that when we have more of a dialogue. But what we're searching for is we're searching for this individual, the one that we're able to help either through, in this case, laser surgery that we do at Mayo Clinic, or in other forms such as open surgery, resective surgery, where somebody actually has to have brain surgery or have neurostimulators. And we have patients that are seizure-free on neurostimulators. But what we look for is somebody who becomes seizure-free, because at that point in time, the quality of life returns back to normal, and quality of life is improved to the point where they can drive, they can gain employment, they do feel better about themselves, they may be able to reduce their medication, they're safer from harm's way where they may be injured or even worse. And that's what I hope to share with you. I wanted to give you kind of a brief overview of epilepsy in a capsule from a neurologist's point of view. What we look at is a little bit different, and we have to have a team approach as we tackle some of the toughest cases that I've ever seen for patients that have epilepsy. I don't know whether Dr. Middlebrooks might want to share some examples of what's crucial to making important decisions about what happens when drugs don't work. Erik?
Thanks, Bill. Yeah, I'm just going to transition and talk about some of the other tools that we typically use in trying to diagnose where these seizures may be arising from, and also how to predict how we can do some of the treatments that Dr. Tatum mentioned. And this area is one where really in imaging for patients with epilepsy, not all scans are created equal. And I'll talk a little bit about why that's important. And one of those tools that we use is the 7 Tesla MRI scanner. And so this is a fairly unique tool that we have. We're one of 6 sites in the United States to have this, and the only in the Southeast region that has a clinical 7 Tesla scanner. And the reason this is beneficial is it provides over twice as much signal and resolution compared to even our current kind of state-of-the-art MRIs at most centers, which would be a 3 Tesla MRI. And the reason this matters is because finding something on MRI has a huge impact on how well patients are going to do after treatment. And for instance, people who do undergo surgery, like resective surgeries, have almost a 3 times higher likelihood of being seizure-free if we find something on their MRI compared to those that we don't. But unfortunately, we still see a lot of patients are what we would call MRI negative with standard MRI scanners. Where the 7T comes in is that it actually allows us to detect lesions much better. And in a summary of what's been published in the literature on 7 Tesla scanners is that it detected lesions in 65% of patients compared to only 22% of patients at 3T. So almost 3 times as likely to find something on a 7T, even when having a normal scan on a standard scanner. And so here are just some of the advantages that we see. On the left-hand side, you can see what we would consider kind of state-of-the-art 3 Tesla MRI scan versus on the right, the 7 Tesla scanner. So you can see that the images look much less pixelated because of the higher resolution, and we see much better difference between the gray matter, which you can see is kind of the grayer area compared to the underlying white matter beneath it. And this is really important for finding these lesions. And so just as a comparison, the 7T images on the left to the 3T on the right, you can see that this higher resolution gives us not only less kind of pixelation in the images, but also allows us to image at a much higher resolution and get more images through the brain. Here's an example of a patient who had had a really extensive workup for epilepsy and had been determined to be negative on MRI. And we can see on the 3T scanners that this area here was not identified because it looks very similar to this kind of artifact that we see in other areas of the brain. But we can see here on the 7 Tesla scanner that it's very clear that there is a dysplasia here, which is a very common cause for epilepsy that is very difficult to identify on standard scanners. We also see this other lesions like this is a vascular malformation that is very common in patients with epilepsy. It's generally kind of a benign lesion, except that they do tend to produce epilepsy in some patients. And this was a lesion that was not identified before the patient came to us for the 7 Tesla scanner. And you can see right here, the lesion is the brighter area, and this dark area around it is the blood products that have kind of accumulated there over time. And then here's another patient that was also considered to have normal MRI on our standard scanners, but we found this lesion that was causing their seizures really clearly on the 7 Tesla scanner. We also see that patients sometimes come to us with incorrect diagnoses. And so this was a patient who had, this is the hippocampus, which is part of the brain that encodes a lot of our memory functions and things like that. And this is something that is very frequently involved in epilepsy. And we see in this case, the normal one on the right side. On the left, it looks kind of smudgy, like you kind of rub your finger and smeared it out. And this was called abnormal, but the problem is this does not relate to what Dr. Tatum's team was seeing with the electrophysiology and the clinical evaluations. And we can see when we repeated that on the 7 Tesla that it actually is normal on that side. So in this case, there was actually a kind of a misdiagnosis that was kind of falsely leading us to believe that the one side was abnormal when it really was not. So here's another example where we see this, the hippocampus here on the left side looks very similar on our 3T scanners to the other side, but on our 7T scan, we can see that it looks much darker on this side compared to the normal side on the right. And this was an abnormality related to the seizures. We also have another tool that is a little more common, but still I think there's only 3 in the Southeast that I'm aware of, is the PET MRI scanner. And so this system combines both a PET scanner, which we use to measure glucose uptake in the brain. That is a very common tool that we use for localizing epilepsy. which is typically combined with a CT scanner, but the CT scanner doesn't provide the contrast and resolution that we would hope to see is with the MRI to better localize lesions. So this actually combines the PET scanner inside of the MRI scanner. And you can see here that this, in this patient, that the right side is really bright, means that it's taking up too much glucose. And then here you can see on the left side that this hippocampus is taking up too much glucose. And so this was a patient who actually had autoimmune epilepsy. And so these were kind of inflammatory changes in the brain, as opposed to what we usually see as the part of the brain that's causing seizures usually is kind of hypoactive and doesn't take up as much glucose. We also use it to localize these important parts of the brain before we consider any kind of surgical treatment. And so Dr. Tatum mentioned this about identifying not only where the seizures may be coming from, but also knowing if that area is what we would call eloquent or is really critical to functioning. And that may include things like motor function. So, if we were to resect, you may lose, hand function, or it can include like language, where you may lose the inability to comprehend or speak. And so it's really important for us to identify those before surgery. And so we can use a tool called functional MRI, which we see on the left, where these red, yellow areas actually show the areas of the brain that are responsible for language in this patient. So we can actually map which side of the brain is most responsible for language. And that lets us predict the likelihood that someone would have a big language problem after surgery. And then we also map other functions like motor functions. So we can look at the parts of the brain that control your hands, your feet, your mouth, and have a better idea of what might be the consequences if we were to operate. And we can also actually map the white matter tracts of the brain. And this is an important model for how seizures may spread, but also these tracts are equally as important to these functions. So interrupting them, for instance, this yellow tract is the corticospinal tract, carries most of the information for moving your body. And so interrupting this potentially results in having a severe deficit in being able to move. And so we are able to kind of map these things out before surgery as well, so that we can understand the risks that may be posed by different surgeries. We also use these systems to improve our ability to target for things like neuromodulation, in particular like deep brain stimulation. And so you can see here on the 7T MRI, this is a sequence that we have devised for implanting our anterior nucleus DBS. And you can see that the green arrow here marks a white matter tract that is really important for sending information to this structure marked by the red here is the anterior nucleus. This is where we're targeting is the nucleus and this white matter tract that connects to it. And you can see that in our standard MRs that are used for targeting traditionally, that you don't really see that stuff here. So you're just kind of blindly trying to put these in without really knowing precisely where you're aiming. And so using this, we can actually find that a very precise point in that nucleus actually gives the best outcomes. And so this is how we treat our patients, is knowing really precisely where the device needs to be and also how to optimize the programming of the device. And so you can see that here, where this is the deep brain stimulator that has been placed, and you can see this yellow here marks the anterior nucleus, and the blue, this white matter tract that I mentioned, and we are targeting right near the junction where these two things join. And so this is an example of a patient where we placed these bilateral stimulators and are able to really precisely target this area to get kind of maximum improvement in seizure control. And so you can see here where this is really optimally placed at that junction. We also look at targeting other structures that are kind of newer targets. And one of those includes something called the Centramedian Nucleus. So this is also in the thalamus, but is a different part of the thalamus. And traditionally, you can't identify this structure on any known MRI sequences. So we kind of went back to scratch and thought of new ways that we could actually see this, so that we could be sure that we're implanting in the right part of the thalamus. And so this is what we came up with, this sequence that we call EDGE. And you can see here, this lighter area that's circled here is the Centramedian Nucleus. So we actually came up with a way to identify this so that we know precisely where to put the deep brain stimulator. The initial that we came up with is about 24 minutes long, and so it was great, but it also took a long time to acquire this data. So this is where the 7 Tesla scanner comes back into play. So you can see here the 3 Tesla images on top and the 7 Tesla images on the bottom. You can see that they have much less noise in them. They're much smoother. You can see these structures much better. Here are the edges of this nucleus right here that we're targeting. And we get these much better images in a fraction of the time. So only 8 minutes compared to 24 minutes with standard scanners. So this really allows us to be really precise with where we put our deep brain stimulators. And this was a patient that was implanted with the Centramedian Nucleus. And we can see that it allows us to place these really accurately to be sure we're on the right target. So I'll stop there and I'll turn it over to Dr. Greywall.
All right, so we just I'm going to tie things together here really quickly before we move on to questions, because we want to make sure that we're able to answer your questions. I want to thank the Epilepsy Florida as well as Medtronic for allowing us to spend some time with everyone today. So just a little bit about Mayo Clinic. You know, we're voted #1 hospital in the state of Florida, and that's by our colleagues as well as by our patients. Some lessons that we've learned over our time doing this is that epilepsy is complex. It's always caused by something, and the goal is working with colleagues like Dr. Middlebrooks on finding out what's causing it, working with colleagues like Dr. Tatum on finding out where it's coming from. It's frequently drug resistant. Epilepsy surgery is underutilized and underappreciated. And we typically say neurologists have about a 2-year, 2-drug window to try standard medications before we've declared resistance to drugs. And refractory epilepsy, that's when you need to see someone like my colleague, Dr. Tatum, an epileptologist, someone who specializes in this. And this is our team at Mayo Clinic in Florida. So for patients, when you come here, you see either one of the epileptologists, some of our research colleagues. We have epilepsy surgeons, but some of the new fields in epilepsy, such as neuroimmunology, Dr. Sebastian Lopez is really a worldwide expert in this. Dr. Waringa is a neurogeneticist who's fantastic. Dr. Gupta, Dr. Middlebrooks, as well as our neuropsychologists. Our group in 1 year posted over 100 publications, multiple book chapters, leaderships in multiple societies, and editorialships of major journals. But it's not just Mayo Clinic Florida, it's Mayo Clinic as a whole that you get access to. And this is just a small sample of our group when we get together. But there's over 50 to 60 people across the 3 sites that are working together to treat our patients, especially the most complex ones. And when it comes down to all those articles and teamwork and everything, I think I really want to leave it at this, which is a quote from one of our founders, Dr. Mayo. And that's the best interest of the patient is the only interest to be considered. And that's something we live by every day here as a group. And I'd like to open it up for questions now.
Thank you, Dr. Greywall. Does anyone have any questions at this?
Yes. Are any? How are you all y'all like any like doctor like affected by epilepsy like directly? Like any of y'all family members have something so you could relate possibly on more of a personal level? Did that come out right?
So I can tackle that one. You know, that's something we get asked quite a bit. Is that why'd you go into epilepsy anyway? Do you have it? Does somebody in your family have it? And the fact of the matter is, most of us that are in epilepsy either identify it as something that we can really truly get our head around and help people, or that we do have somebody in our family. I can tell you from my standpoint, my niece, my sister's kid, had a febrile convulsion, and she called me up crying. And she said, my baby just had a generalized convulsion. She works in healthcare. She's a respiratory therapist. And so she knew what she was looking at. but I'll never forget the panic in her voice. And even though she was very highly educated, it took a very long time to settle her down, to suggest that this is something that happens in kids. It very rarely goes on to develop into a chronic, recurrent seizure disorder, which she later found out. But it was a devastating moment for the family. And so that's my personal experience and exposure. But I would suspect that there's many more. And I would also suspect that you could go to any profession, doctors, lawyers, politicians. We've seen them all. It doesn't spare anyone. And so I would bet that many people working within the field of epilepsy either know somebody or may even have it themselves.
Yeah, I'll say growing up, my stepbrother developed epilepsy when he was in high school, and he was a tremendous baseball player, was, scouted by pro scouts, and he could not play anymore. When he would get out and get hot, he would have repeated seizures. They could not get them under control, and it really kind of upended all of his plans. And so I think, we have, a good understanding of how impactful it can be to people's lives. And so, in my field in radiology, we really kind of see the spectrum of all neurologic diseases. And so, we have to kind of master, all of these kind of things. But I think, being able to focus and work really closely with our epilepsy team has really made a big difference in, not only our capabilities, but also, my own experience. And so I think really the teamwork is, I think we all kind of support each other well and reinforce each other's capabilities. And I think that's really one of the keys to having, good treatment plans.
Yeah, I'll just add on to that. But I think all of us have somewhat personally been touched by epilepsy. So I have two separate uncles on two separate sides of the family who have had epilepsy, and part of the impetus for us to go in this is you feel what it's like day to day for your family members to go through this, and you want to do everything you can to try to stop it. And that's kind of our goal and mission.
I know I came late. I just want to say a big thank you to Dr. Tatum, to Dr. Middlebrooks, and to Dr. Grewal for joining us. We had, it was an amazing lecture, and thank you so much for the information. I think it was very educative. And for you, Aljit, I want to say thank you for your question. And yes, even if we don't have family members, and I have two family members who were touched with epilepsy, and one of them was my cousin, and he had severe mental disorder, and they didn't know it was epilepsy. They thought he was just acting up and having some mental breakdown or some other mental issues, but in fact he had seizure, and he even lost his eye from a seizure. And I was born and raised in Morocco, so they didn't have much understanding about it, which is very unfortunate. And also I had another cousin who was lucky to go to France and have surgery and became seizure free. Now, beside our personal experiences, our patient become very close to us. That's what we chose this field, because we feel as neurologists, we chose to become epileptologists because we can change people's life with their help as well, when they're very compliant with their medication and follow instructions, and is in one of the subspecialties in neurology where there is hope and there is much to do. And now with all the advance and the medication, the semi-invasive, the invasive treatments, there is miracles that happen for seizure patients. And that's the message I want to give you before I leave, and say thank you all, because I have to join another meeting. I apologize.
So
Thank you very much.
Dr. Katani, if I could just add on to that, you said something very, very important about your cousin. And one of the things, as you know, we run into is that difficulty with diagnosis for people that aren't really familiar with epilepsy, right?
Correct. Absolutely.
So we see not infrequently when we admit people for an evaluation that maybe 30% or more don't actually have the diagnosis of epilepsy that they're being treated for. Now, I
Absolutely.
suspect the audience is probably composed of those that do. However, it's really important that until you're given a definitive diagnosis, to keep that search going, to make sure that you have a diagnosis and then have a treatment plan with medicine, and then maybe other things that are a little bit more aggressive in terms of treatment. But it's a very important point, I think, for the audience.
Yes. It goes very often very unnoticed and unknown because everyone thinks seizure is just the convulsion and the dramatic manifestation
Exactly.
of but brain is like a map if it's involved in the sensory and the where there's interpretation of your feelings, and you may have some sensation and you just think you're crazy because you're having feelings and you don't understand, but these can be seizures and they can progress to worse if they're not addressed properly. But that's beyond the question. But just to
Well,
let you know that you're not alone. That's why we had came up with this program that seizure is very common, very frequent, unfortunately get misdiagnosed. But the good news now, a lot of people are more aware of it. And we as epileptologists do our best to educate other providers to diagnose it early and refer early and encourage them to send their patient to us for the epilepsy, and they could see their physician, their patients for other conditions they're following them, so they don't lose their patients. But I also request from people who suffer from this condition to be proactive and also always seek a second opinion, because it does not hurt. In fact, it helps. And no physician who respects themselves will be offended if you go ask another provider their opinion. And I strongly encourage it.
right.
And with
Another
that, I'll
thing-
say.
Another thing that we're doing now is we've just completed a multi-center prospective fancy study looking at a common tool that's a new tool in the toolkit. It's a smartphone. So when there's a doubt, if patients take a smartphone video of the episode, it can be as helpful as somebody spending an hour with a qualified doctor like Dr. Catani or myself, who see patients with epilepsy and diagnose them, compared to 2 minutes that it takes to use a smartphone. So it can be very, very helpful. We're recommending that now to all of our patients in the clinic.
I just want to say one last thing. Thank you, Dr. Tatum, for comparing me to yourself. I appreciate that. That's very humbling.
We have the same training. We have the same training.
Yes, thank you so much. I'll take that. Thank you, appreciate. Thank you very much, everyone. I have to join the other meeting. I'm sorry. Okay, thank you.
Thank you, Dr. Catani.
Yes.
So we did have a few questions in the chat. The first one was from Pauline. She's asking, is access to a 710 easily available?
I would say at our site it is, but we are the only one in the Southeast. So the 7 Tesla scanner is prioritized towards people who would benefit the most from its use, which includes epilepsy and a few other disorders. And so I think Dr. Tatum can share his experience from the ordering perspective, but I think we pretty promptly get them in within anywhere between 1 to 2 weeks on average.
Yeah, so I would echo that. Number one, we're fortunate enough not only to have the machine, the 7 Tesla, but to have Dr. Middlebrooks, because it's not necessarily the tool, it's the carpenter that tells you what's wrong with these images. We see all kinds of stuff that we never saw before. So sometimes you can get carried away by finding too much that doesn't necessarily fit with a clinical condition of the patient. So we recommend that there's access to anyone that's an appropriate candidate through the Mayo Clinic, through one of our epileptologists that can then provide the proper ordering, or through neurosurgery that can then order the appropriate study with the appropriate technique, so that experts like Dr. Middlebrooks can can interpret it correctly. An example was one that was shown, that left abnormality within the hippocampus of the temporal lobe, somebody that didn't have the seizures that began there at all. So we can get lost in the weeds and look at the forest by speaking with patients and their family members or their spouses, significant others, to define exactly what type of epilepsy syndrome they have to begin with. Because without that type of foundation, all the other tests are just extra.
Thank you.
Yeah, I'd like to just add on to that. You know, the 7T has been an excellent tool, and having Dr. Middlebrooks and his colleagues is extremely helpful for us, but you really need a multidisciplinary approach for this. So you need people like Dr. Tatum to say, hey, we think this is coming from the left temporal lobe. Dr. Middlebrooks, look really closely at this area to make sure we don't miss something that's very subtle. So, you know, the imaging is great. It's very, very helpful. But if you don't have the whole picture together, then you're not getting the appropriate care.
Thank you. And while we are still on the topic of the 7T scan, we have a question in the chat wanting to know if this is typically covered by insurance, the scan.
Yeah, so you know, it's always a case by case issued, you know, that's kind of multifactorial, but it's the scan itself is not billed or anything differently than a standard MRI scanner. So generally, these are covered by you know, with the diagnosis of epilepsy. There may be some additional challenges if, for instance, if you had just had an MRI. To have another one repeated right away. And Dr. Tatum may be able to kind of fill in, you know, the details on his success of being able to get those approved with insurance. So it's not always 100% that, you know, that it may require a little bit of, in some cases, a little bit different approach. But in general, they should be covered as would be a standard MRI scanner.
Yeah, I mean, I think that's exactly right, Erik. I mean, we get these requests all the time, and the diagnosis that has had the least resistance has been one of drug-resistant focal epilepsy, because it's very clear that in those cases, when somebody's drug-resistant, that is, that they failed 2 drugs at an optimal dose for an appropriate period of time, that the likelihood that they'll continue to respond to drug number 3, drug 4, 5, 6 is very small. It's 5, 10% at the outside. So insurance companies have not given us much of a problem with the pre-approval process that we sometimes have to go through to have 7T reimbursed by a third-party payer.
Thank you. So another question, this is from Joelle. If you're having bad side effects on Keppra, what can you do?
Well, since we use lots and lots of anti-seizure medicine, there's probably about 30 of them in the world right now. There's other choices. And if you're having side effects, that's considered a failure, especially when they're moderate and constant throughout the day. And there have actually been a series of studies, about 4, that look at seizure. I'm sorry? Something happened. Anyway, I was just going to say, side effects can be even as much or more important than reducing seizures if you don't become seizure-free. So they're very important to identify, and if you have them with levetiracetam or Keppra, there's many other choices that may be excellent substitutes, and you should change.
Thank you. Thank you for your question, Joelle. Linnell is asking, is it always accurate that if you've had surgery on one side, you're gonna need it on the other side?
Dr. Greywall?
The answer is no. So, you know, our goal with surgery, when we're talking about something like a resective surgery or laser ablation, is really to find the spot and take care of it. And that that's when we quote patients 70, 80, 90% seizure freedom rates. That's if we've identified the right spot and then we've treated it. When we're talking about surgery on both sides, that's when we're talking about things like neurostimulation, but that's all done at the same time. So for example, what Dr. Middlebrooks was showing with the deep brain stimulation, putting those 2 electrodes in while you're asleep to try to modulate the networks, we do that all at the same time. So it's not really that you need the surgery on the other side. It's just that we want to impact the whole brain as a network and not just one part.
Thank you. There's another question in the chat from Pauline, and this is going back to the question about if you guys have any family members that have epilepsy, and she's asking if your family members have their epilepsy under control.
So I'll start off, and I told you about the febrile seizures in my niece. She was okay for a while, but she had bipolar disorder, and she has uncontrolled seizures now on 2 different anti-seizure medications.
Yeah, similarly, they're periods of control, but not long-term, unfortunately.
Yeah, controlled when you're on medication and avoiding kind of the triggers, which, you know, is can be easy for some people depending on what the trigger is, but obviously can be, you know, quite devastating to the things you want to accomplish in life. So yeah, that's so unable to do much activity.
So I think one of the tough things that we see in epileptology is trying to weigh the disability in somebody that has 1 or more comorbidities, such as my niece that had bipolar disorder, which wasn't controlled, and her seizures were relatively infrequent. So if you took away those seizures, she'd still have bipolar disorder, and that was what was disabling for her. So even though sometimes you do see something that's a diagnosis such as drug-resistant epilepsy, or you see something on the MRI, it doesn't necessarily mean that's the disabling feature of the individual that has recurrent seizures. So it's a balance. It's a balance that requires a lot of thought and approach relative to what's the right treatment for that patient. I saw something in the chat room or chat about insomnia. And sometimes we get wrapped up in terms of people that have more than 1 comorbidity and then have side effects from the medicines that are being given to try to help them. And we have to try to disentangle that so that when we're interpreting an MRI or interpreting an EEG, or we're considering surgery or a laser or a deep brain stimulator or responsive stimulator, vagus nerve stimulator, that we have all the cards on the table so that we can identify and solve what we can solve, and then attack the problem that's accessible, disabling, in a patient that's motivated to undergo a major procedure.
Thank you. We have a question from Kareem in the chat. Kareem, if you want to unmute yourself and ask the question, I'm not quite sure what it is that you're asking.
Let's recommend, no recommend, I was told that I can have the RNS, even though that I have operation on the right lobe. I asked this personal, and she told me that I can still have the RNS, put it in my brain or my skull. I just wonder if how rest it is now that I'm from having seizures almost 2 times a week, 4 times a week, depending, to don't have any. However, I start having tickles in my body, which I believe that's part of the seizure because I had it before, and I'm starting getting doing that now. So I don't know why.
So I can address that for you, Kareem, and thank you for your question. And your symptoms are very important in terms of reflecting the area of brain that's responsible for generating the seizure. There could be overlap, like we talked about, relative to the epileptogenic zone and that which causes symptoms, but they tried to help you through an operation, and it sounds like it didn't completely solve the problem. You can have an RNS. The RNS can be used as a supplement to the surgery, and it can be applied, that sensing and delivery of an electrical current, almost like shocking the heart that you see on TV when someone's had a heart attack, by placing that electrical stimulus right in the area. But we got to know the area, and there can't be more than 2 places to put the electrical devices that record and deliver the stimulus, the electrodes. So your doctor is trying to be honest with you, I think, that there may be more that could benefit you.
This hasn't told me I was not qualified. He told me only that I was qualified. I was they be able to do operation. But I would have to stay on the hospital, which I did. And I have, you know, I did the operation because I qualified for it. But now they send me an email that I remember that I wanted to have it a long time ago before the procedure. So that's why I was brought it up here on well, if you don't want it, or it's an optional,
Yeah, I
to
think
me.
honestly, I think it might benefit you for further information, a second opinion. You know, at Mayo Clinic, we often see people that have been seen by 3, 4, 5 other physicians and or several centers. So we're used to seeing things like that. And oftentimes it's hard to get a feel without additional information. So I think an open dialogue with your doctor would help, and or further pursuing something that would make you more comfortable, like a second opinion. I think that's a good idea. Yeah. Thanks for your question, though.
Thank you, Kareem. Okay, our next question is from Eileen in the chat. She's asking, can dysautonomia cause seizures too?
Interesting question. I'm curious to hear some of the thoughts behind that. I can take that one, because we see people with some very difficult cases that ultimately wind up being dysautonomia. And some of the reasons they come to us in epilepsy is because with dysautonomia, the autonomic nervous system isn't functioning properly. And because it doesn't function properly, there may be changes in heart rate. There may be changes in the tone to blood vessels that create a low blood pressure and a low blood flow to the brain. And the brain responds with only a few different things that it can do. And one is to pass out. And if you pass out and you have a lack of oxygen from a lack of blood flow for a long enough period of time, your body stiffens because the brain reacts, and you can look like you're having a seizure. And if it goes on for the long enough time, too long, you can injure the brain and change what looks like a seizure but is not, to something that actually may be an acute symptom that is a tonic-clonic seizure. Now, typically, we don't treat these with anti-seizure medication unless there's some underlying abnormality of the brain. So dysautonomia can be associated with seizures. It can be associated with, more commonly, seizure mimics, things that look like seizures but are not, and not epilepsy. So it's a very important distinction, because if you go based on what things look like, everybody's going to wind up on seizure medication that has dysautonomia. But the key is, as we talked about before, diagnosis and treatment.
Thank you. Thank you for your question, Eileen. We have another question from Linnell. She says, what are your recommendations for better memory function?
Dr. Greywall, did you want to tackle that one?
I usually have them see my colleagues, Dr. Sapsovitz and Dr. Blackman for that, but I'm just kidding. I think there's really two important things here. One is stopping the seizures, right? Depending on where your seizures are coming from, we know that the burden of having those seizures over time can worsen your memory. And if we can stop those seizures, we can start to improve the memory or at least halt it from getting worse. Additionally, sometimes it is a medication-related effect, and it might be a good idea to try a different medication or a different dosage of medication to try to get these memory issues to improve. Dr. Tatum, anything to add to
No,
that?
so that's 100% true. And where patients suffer mostly from problems with memory are those that have focal seizures that arise from the temporal lobe. And the temporal lobe houses an area of the brain called the hippocampus. Temporal lobe epilepsy is about 70% of what we see with focal onset seizures in the adult. And the inside part, the hippocampus, responsible for about 70% of seizure onset. And we know now that over time, people with temporal lobe epilepsy may progress in terms of their memory problems. But as Dr. Greywall said, we have medicines such as topiramate or zonisamide or phenobarbital, or sometimes some of the clonazepams or the benzodiazepine medicine that can impair memory, short-term memory. It's not the things that typically happened long ago. It's the here and now. What did I have for breakfast this morning? What did I wear yesterday to work or to go to school or whatever? It's the here and now, and you can't typically give back memory. You can undo something that's insulting the current memory that you have by changing medicines. But frequently we do involve neuropsychology to find out how bad is it? Where does the problem lie? Can we offer some type of cognitive rehabilitation therapy? And we have specialty people at Mayo Clinic that identify and then try to augment the memory that's there based on cognitive rehabilitation programs that we have. In short, it's very common and it's a hard problem to attack. I don't know that you disagree, Dr. Greywall.
Nope, I agree with most things you say, Dr. Tatum.
And I'm glad you were given the opportunity to address that question first, because it's a tough one.
Thank you.
Good evening. Can I say something?
Yes.
My name is Ava, and I'm late to the meeting. My daughter was in the hospital. Yes.
I'm sorry to hear that, Ava. Did you have a question for us?
And yes.
Eva, we don't have a good connection. Do you want to try sending the question through the chat box?
It's a beautiful picture. No.
Eva, I'm so sorry, but we can't hear you.
My question really is,
I don't think we're going to be able to understand the question. It's a bad connection, but maybe Rachel, we can make our emails available to
Absolutely.
you if there's any questions after the tea time, that you can help connect us with those that still have questions.
Absolutely. I will definitely do that. We have reached the end of our hour. Wow, that went by so quickly. Such wonderful, invaluable information. On behalf of Epilepsy Florida, I want to thank all of you for joining us tonight. I want to give a special thanks to Dr. Katani, Dr. Middlebrooks, Dr. Greywall, and Dr. Tatum. Thank you so much for spending time with us this evening and providing this information. A huge thank you to our sponsor, Medtronic. We're very grateful. And we do hope that you guys will join us at our next tea time.
Thank you.
Thank you all.
Thank you.
Have a great evening. Thanks, everyone.